Hi, everyone. This is John Mandrola from the Heart.org Medscape Cardiology, and I'm delighted to be with Professor Bruce Neal, who's a professor of medicine at the University of New South Wales in Australia. He's primary author of the SALT Substitute and Stroke Study, which was presented as a hotline to European Society of Cardiology and published in the New England Journal of Medicine. This is a really important trial. So welcome, Professor Neal.
Hi, John.
Can you give us, this was 20,000 participants, can you give us the top line and key findings of this important study?
Sure. So we randomized 21,000 people, as you said, to either a salt substitute, which was a reduced sodium added potassium alternative to regular salt. And we followed them for about 5 years. We accrued about 3,000 strokes, 4,000 deaths, and 5,000 major adverse cardiovascular events during the study, and we saw clear protection against the risk of stroke, so a 14% reduction in the risk of stroke with a p-value of 0.006, and we saw clear protection also against the two secondary outcomes, one of which was total major adverse cardiovascular events. That was a 13% reduction, and also against premature death, and that was a 12% reduction, and both of those two results had a p-value less than 0.001. So pretty clear evidence of efficacy. The other key observation was that we didn't see any increased risk in hyperkalemia, which has been the concern with using a salt substitute. So the risk ratio there was 1.04 and the p-value was 0.76. So a pretty compelling result.
And this was an extremely unique sort of trial environment, wasn't it?
Yeah, look, we did the study in rural China because it's a great place to sort of test the hypothesis, because to test the hypothesis of whether reducing sodium, adding potassium would actually change outcomes, you of course need to be able to reduce sodium and add potassium to the diet. And in rural China, at least 50% of the dietary sodium that people eat is actually consumed as salt that you add either at the table for seasoning or when cooking or when preserving food. In more developed countries, a lot more of the dietary sodium comes from processed and packaged food, and it's much harder to replace it.
Yeah, and there was also a unique trial design, and the cluster randomized trial is something that normal cardiovascular trials really, we're used to individual randomization. Tell us about that, and tell us how to understand this whole cluster randomization thing.
Yeah, so we didn't, as you say, randomize the 21,000 people individually to salt or salt substitute. What we did was we had 600 villages, and in each of those villages, we recruited 35 people. And then we randomized the villages, so that group of 35, to either the salt or the salt substitute. Now, you lose a bit of statistical power when you use this sort of design, but you make up for it in other regards. And in this study, the reason we did the cluster randomization was because it was much easier for us to deliver the intervention, the salt substitute, to a group of people in a village, and not have two people who might be in the same village, one using one thing, one using the other, them asking questions, and the whole thing getting really complicated. So that was why we did it. And if you've got a large number of clusters, you don't miss out that much in terms of the statistics.
And you had a really big, really significant and robust reduction in hard outcomes from a salt substitute. I noticed that the patients were pretty high risk. This was clearly a sort of a secondary prevention or high risk population. Tell us about the patients.
Yeah, so the patients were either adults who had a history of prior stroke, or they were aged 60 years or over with poorly controlled high blood pressure. And again, we chose that group not because we believe that's the only group it's going to work in, but because that's a group that's going to have the large number of events that we need to test, what was frankly a relatively modest relative risk reduction of 13–14%. What we did have, however, though, was great power to look at effects in subgroups. So while the study was done in a mostly high risk population, we saw benefits in people who had a history of stroke, but also in those who didn't have a history of stroke. We saw benefits in the hypertensive people as well as the non-hypertensive people, etc.
And I noticed from the New England paper and your presentation that the mean blood pressure reduction was really kind of modest at only 3 millimeters of mercury. How do you explain such a robust finding in heart outcomes with that degree of modest degree of blood pressure reduction?
Yeah, well, I mean, people forget just how important a risk factor blood pressure is. 3 millimeters systolic doesn't sound like much when you're sitting in a clinic, but actually 3 millimeters systolic blood pressure lowering is pretty powerful. It's not that different to what you actually observe in some of the large scale trials of blood pressure lowering. So for example, ACE inhibitors, angiotensin receptor blockers, that probably have most of their effect through blood pressure lowering. They don't lower blood pressure a great deal more than that. In this study in China, I mean, we were studying stroke. Stroke's uniquely sort of responsive to blood pressure lowering. And in China, you also get a slightly greater proportion of hemorrhagic compared to ischemic strokes, and hemorrhagic strokes are even more sensitive to blood pressure lowering. So I'm pretty sure this is a blood pressure lowering effect that we see in SSaSS, not something else.
And one of the questions that came up amongst colleagues was to ask you about the operational challenges of working with cluster randomization in villages in rural China. I mean, it's kind of atypical for cardiovascular trial. How would you explain these challenges, or are you confident in the results?
Yeah, look, I'm really confident in the results. I've had the good fortune to be working on the ground in China for almost 25 years with colleagues there now, and we have really strong teams, really good relationships. One of the things that really helped us though was that the Chinese have a sort of universal health coverage insurance system in the rural areas, and what that means is that if you have a serious event and end up in hospital, you get most of your healthcare cost for that event reimbursed. Now, as a consequence, when we did this study, more than 99% of people were actually signed up to that system. So it gives you this phenomenal capacity to track people and know whether they're dead or alive, and also to identify whether they've been to hospital or not. So we were able to get phenomenal follow-up. I mean, we reported absolutely complete follow-up for vital status in this study, which I've done a series of other large-scale trials. I've never been able to report that before. So pretty confident about the quality of the data.
Interesting. Let me just ask you to speculate. I mean, there's so much has been said about salt and salt's role in hypertension and health. I mean, how do you think these findings inform that sort of sodium debate?
Yeah, so the debate has been around, is there a risk associated with reducing dietary sodium? And frankly, a lot of that is based on some fairly weak observational epidemiology. So I've never been, a great believer in that as a concern, but it's a very real concern out there. So what do we add to that? Well, we're not going to answer every skeptics questions because we didn't lower dietary sodium down to really low levels of consumption, but we clearly showed that reducing dietary sodium and adding dietary potassium was a very safe and effective thing to do. So I'd love this to be the final word on the debate. It's not going to be, but I think that there is a message here for many people, because almost everyone eats salt and almost everyone eats more salt than they should. And more likely than not, this result is relevant to all those people. My sense is that this is something that it's certainly something that I would do if I did eat salt, which I don't, but I will be recommending to all my friends.
And that gets me to, I guess the follow up to that is you sort of did two things with this, right? You reduced sodium and you added potassium. And do you have a sense, or will there be sub-studies that probably, will you be able to tell which of the effects sort of predominates, or is it just both?
Yeah, so we wrote the paper up very carefully to try to stay out of that debate and just went, we used a salt substitute. It was really effective. You should do that, because we think that's the most pragmatic, reasonable message to take from the paper. That said, the population that we studied, they eat quite a lot of salt. They don't eat that much dietary potassium. There is no doubt that this was an effect that was driven by both reducing dietary sodium and supplementing dietary potassium. If you started off eating a different ratio of sodium potassium, you might get a different proportion of the benefits from taking out the sodium versus adding the potassium. It's something we haven't worked out for this study yet, but it's certainly on the list of things to do.
And I guess in terms of translation, I read in the paper, and I've read that, you know, in the United States and elsewhere, so much of our sodium comes from processed food, and we can't really control that. How do you think that this informs policy decisions in terms of our food supply? I mean, a few years ago, we took trans fats out of the food supply, and that seemed to reduce events quite significantly. You know, could the same thing be said for salt substitutes in processed foods?
Yeah, so in terms of processed foods, I mean, we think there's definitely a message here for the food processing industry. Again, they've probably not felt a particularly strong need to act on dietary sodium in processed foods because the evidence has been a bit lacking and there's been a lot of debate there. We hope that this will provide a new impetus to the food industry and to people who hopefully regulate the food industry to say you really do need to put less sodium in, and you need to try and stop all that potassium that was in the fresh fruits and vegetables at the beginning from being leached out during the food processing. How you might, regulate that? Well, there are a few countries which have tried to set standards around maximum acceptable levels of sodium. I don't know anyone that's done anything around potassium levels. You can, of course, label foods, and there are a range of different ways of labeling the overall healthiness or specific constituents like sodium. So that's a possibility. I think that the bigger piece in terms of rollout and implementation that we'd like to see is really the focus on low middle income countries where more than 50% of dietary sodium does come from discretionary salt that could be directly replaced with salt substitute. And the key there is probably going to be making salt substitute the same price as regular salt, as well as making it widely available on supermarket and shop shelves.
And my final question, and again, this came up with discussion with colleagues, is there a taste difference with the salt substitute? And I guess the corollary to that is, if there is a taste difference, could there have been an issue with blinding in the trial? And then if people knew they were on the salt substitute, they might do other things that help reduce their stroke.
Yeah, so I'll take the two things separately. So the first of all, in terms of the blinding, I mean, this was an open study. We only provided the salt substitute. The people in the control group just continued using their regular salt. And what we did to try and control for that risk of blinding is we used really hard outcomes. So it's hard to make a mistake about whether you had a stroke. It's very hard to make a mistake about whether you died or not. So I don't think the results have been adversely influenced by the fact it was an open, not a blinded trial. In terms of the taste piece, we chose this particular mix of sodium chloride, potassium chloride, 75-25, because it does taste very similar to regular salt. If you cook with it, if you add a lot of it, you can get a slight bitterness. If you use slightly more sophisticated products available on the shelves of some Western supermarkets with a little bit, I think they're amino acids or some flavor enhancers, you can pretty much get the flavor identical. So taste shouldn't be an issue. And we had 92% of people still adherent in the intervention group at the end of 5 years. I mean, I don't know another trial, certainly of drug therapies, which have no taste that's achieved that. So I don't think it'll be a big issue.
Well, Professor Neal, it's really an honor to talk to you, and congratulations on this really important study. I mean, we review a lot of studies, and this is a really special one. So thanks for being with us.